Thank you for joining me in this session this afternoon. Just by way of brief introduction, my name is Kiana Dixon. I am a pharmacist by background and by training. I currently specialize in content development, the content creation of educational programs with the Accreditation Council for Medical Affairs, or the ACMA. So the purpose of the ACMA, or our focus, is really to set standards in the life sciences industry through medical education, as well as through technology services as well, like AI, right, for field reimbursement teams. Our topics that we like to focus on here, especially today, is surrounding prior authorizations, as well as patient access and field reimbursement. Now, this afternoon, we're going to navigate this next 40 minutes or so by first addressing and reviewing the current workflow process of prior authorizations, right? Prior authorizations are very complicated. There's a lot of hands in the pot. So we're going to take a look at this process by approaching it as if it's a game, like a game board. We're going to address and follow the journey and the role of each player in that game in this prior auth process. Then we're going to follow up at the end, and we're going to discuss the importance or the medical education that is available to improve the prior auth process through certification, right? Through the ACMA's program, the Prior Auth Certified Specialist Program. All right, so let's get started. All right, this is the game board that I mentioned, right? There's a lot of arrows, there's a lot of players here. It can get confusing. But throughout, again, this session, we're going to address each player. We're going to follow along the arrows. But before we get started, just as a quick recap, as a brief background into prior authorizations, right? Prior authorizations are a means of the payer, the insurance plan, the health plan, whether that's employee-based or government-sponsored health plan, they impose this prior authorization as a requirement that's later going to force the provider to explain why a medication or a service is medically necessary, right? They have to establish this with clinical documentation through some paperwork on their side, and they have to do all of this before the payer, the insurance company, actually decides if the beneficiary will get this medication, right? There's a lot of hands in the pot. It's no secret that prior authorizations are very confusing, that they're complex, that they're very time consuming, right? There's a lot of hands in the pot, and we're going to follow along. So first, taking a look at this overview of our game board, we're going to address all of these arrows you see here on the screen, right? The white arrows you see is the journey of the patient when they visit their provider and then they visit their pharmacy, okay? The red arrows you see is the rejection of or the requirement of a prior authorization. And that's why you see that these red arrows, they start at the pharmacy first. Okay, so the pharmacy notices that there's a requirement of the prior authorization. They send that notification to the provider, right? The provider sends in that clinical documentation, and then they send that off to the payer organization. The green arrows you see on the screen, now these green arrows, they signify or show the communication of that decision of that prior auth claim. Whether that was an approval or denial, that's going to start at the payer, and we follow those green arrows to follow the communication of that decision to the provider, to the pharmacy, and then to the patient, okay? Again, throughout this session, we're going to navigate each player you see here on this game board more in depth. And we're going to do that by taking a look at their perspective throughout this journey. All right, so the first player we're going to look at is the patient, right? Ultimately, the patient, that's who we care about. All right, so the patient's journey. The patient, they fall sick, right? They are ill. They are experiencing a worsening disease state. So what do? They go and see their provider, right? They go to their provider's office to be seen, to be diagnosed, and ultimately the provider writes them a prescription, right? This prescription really symbolizes a sense of hope for the patient, right? They're going to feel a little better, right? Hopefully our outcomes, our health outcomes for this patient is going to improve. The patient then takes that prescription to their pharmacy. They're ready to pick up their medication. But then when they get to the pharmacy, the prescription is rejected, okay? The patient, they're hearing terms thrown around like prior authorization, adjudication, you can't get your medication. The patient is just left confused. right? As a pharmacist, I've been on the other side of that counter, seeing this confusion on their face. No matter if they've been here before or not, that term prior authorization, that confusion is never hidden on their face, right? They're very confused. They're asking, is this normal? Am I the only one experiencing this? Is this something that my doctor didn't do, right? My doctor, they didn't tell me anything about this possibility of whatever you're telling me, a prior authorization. I've never heard these words before, right? The patient then starts to go into, survivor mode. They're looking to see if they can do something themselves to spur this process along, right? They went to the pharmacy expecting to pick up a prescription, and now you're telling me I cannot. Again, they're very confused. At this stage in the pharmacy or in the patient's journey, it's very key, it's very important that the pharmacist, the pharmacy technician, whoever is educating the patient on prior authorization is doing it with patience, right? Patient education is very key at this point, because if the patient leaves the pharmacy and they're still confused, oftentimes, right, patients, they go back to life, to their job, to their family, to their kids, right? And they can completely abandon their treatment if they're lost in follow-up. Or if they are in follow-up, it takes days. It can take up to weeks before they hear back on when they can actually pick up that prescription. Right? So again, this is where it's very important to educate the patient so they don't abandon that treatment ultimately. All right, the AMA, or the American Medical Association, each year they survey physicians nationwide, and they're surveying them to monitor the impact of prior authorization specifically on their practice. Earlier this year, AMA, they reported that 94% of physicians, they reported that the treatments that require prior authorizations delayed patient access or delayed the patient's care to their initial treatment plan. I was here last year at Healthcare Advocate Summit, reporting and showing and exhibiting this same data, the same results from last year, and it was actually 93%. So for me to update this slide and it now says 94%, to me we're seeing an increase, right? From last year, we haven't seen any improvements. Physicians are still kind of pissed off at what's going on with prior authorizations, right? And to me, it's a question as to, at what point are we going to say and do something? Is it going to say 99%? Are we going to wait until all prior authorizations or all physicians report a delay in their patient's care before we do something about it? All right, so let's take a look at some data or some analysis that was provided on the grand scale of spending on hospital care versus out-of-pocket retail prescription drug costs. Right. Patients face higher out-of-pocket costs at the pharmacy counter, even though the U.S. total spend is more so on hospital care than those retail prescription drugs. All right, so let's look at this data analysis here and looking at these graphs. The one on the left, this is our total U.S. spend. And we can see that in total, the U.S. spends about $800 billion with a big B dollars more on hospital care, the lighter yellow, than they do on retail prescription drugs. Now, when we compare this graph with the patient's graph, right, this is more on an individual level, we see that patients pay more out of pocket for medicines at the counter, at the retail pharmacy counter, than they do for hospital care. So we see that opposition there. Okay, so let's go back to our game board, right? We've viewed the patient's journey, right? The patient went to their provider. The patient then received a prescription for whatever illness or disease state that they were experiencing. And then they visited their pharmacy. Then when they got to the pharmacy, those red arrows, we have a rejection. We have that requirement of the prior authorization. All right, so let's go to the next player here in our game board, and we're going to take a look at the provider's perspective throughout this process. Alrighty, so if there's anyone here that works in a clinician or in a clinic office, they're a physician or they're working in a provider's office, you can tell that providers at this stage in the prior auth process are very frustrated, right? We're going to go over why, but here physicians, they're hearing from multiple stakeholders, they're receiving calls from multiple people, from the pharmacist, from their specialty pharmacy, from their patient, right? They're on one prescription. Right. A provider, they are not only dealing with the patients that they have to see this day, but now they have to add on top of that clinical justification, paperwork, right, to submit this data for their prior authorization. All right, so the provider's perspective throughout this process, they're the ones at the start, the initiation of prior authorizations and completing them, right? The HCP, the healthcare provider, they prescribe that medication with the prescription, and that's where we identify that need for an authorization. The next step is documentation. The need for prior authorizations is the insurance company telling the provider or the prescribing physician, hey, we need you to justify why this patient even needs this medication in the first place. So what do? The provider's office, whether that's the physician themselves or other staff in the office, they're gathering and they're compiling all this data as to why they wrote this prescription, why this particular medication is necessary for this patient, right? And then they're going to submit all that data through different modalities to the payer, to the insurance company. Right, the modalities that we see most often are online via a portal, right? But they can also be done via the phone, via fax, right? 2023, we're still doing faxes. But that's also another way of how they can submit their prior auth clinical justification to the payer. Some of the roles involved at the provider level, again, physicians or those prescribers, such as nurse practitioners, they can submit prior authorizations on their own, but oftentimes we do see more staff involved in this process, right? They're the ones who are working to make sure a patient gains access ultimately to their medication. Right? So our patient access coordinators, our financial navigators. Sometimes we have case managers at a provider's office or at a hospital or prior auth specialists. Okay, from that same survey that we mentioned earlier from the AMA, the AMA reports that physicians and their staff spend an average of about 14 hours only on completing prior authorizations each week. Now, these 14 hours, this is a big number, right, just to be doing paperwork. But where this 14 hours really matter is that these are now 14 hours taken away from direct patient care and now being afforded to, again, completing clinician forms, to compiling clinical justification after they've already made that first decision, right? From this AMA survey, they also said that physicians are now hiring staff to solely work on prior authorizations each week, right? This could be great because now we have more people, more jobs, right? More time that is freed up from the provider. But what this causes is, while we have new people that are hired on solely to work on these prior authorizations, we now have to support those salaries. How are we going to support those salaries? They began to bring in more patients, right, to support that. But when we bring in more patients, great. But now we have an increased likelihood of more prior authorizations that's going to come into this office. So now these providers' offices, these clinics, they are now cycling through this cycle of labor costs. It's continuous, right? And we're trying to figure out, where can we just cross it out? When can we stop this cycle of labor costs? All right, so we're back at our game board. We've reviewed the patient as a player, we've reviewed the provider as a player and their perspectives in this game. Now we're going to zoom in and let's take a look at the pharmacy's role. All right, so at the pharmacy journey, at the very start, we've processed a prescription through a beneficiary or through a patient's insurance company, and we get this big term, adjudication, right? Some information is required before we can actually dispense this medication for our patient. Oftentimes, or specifically, we will see prior authorizations for specialty medications. In a quick summary, without me being here very long talking about biologics and biosimilars, specialty medicines are those that are really expensive. They're commonly our high-cost medications, and of course, those are the ones that are undergoing the prior authorization requirement. Now, this is important because in the last decade or so, we are already seeing an increase in medical spending solely on specialty medications by at least 30%. Right, so we're seeing an influx of more and more expensive, high-cost drugs, which is driving up the need or the process of prior authorizations more and more. All right, so let's go back to the pharmacy journey. So I've let the provider know as a pharmacist, hey, you guys need to submit some documentation, some clinical judgment calls to the payer so that I can dispense this medication. On the pharmacy side, I'm really just playing the waiting game. I'm waiting to hear back from the payer side or from the provider, someone to tell me that, hey, we're good to go. Go ahead and try and refresh and resubmit this claim through the patient's insurance company. So at the pharmacy level, our role here in the prior authorization process is to verify the patient's insurance coverage and communication. Here at the pharmacy, communication is key. We mentioned that patient education is very important at the pharmacy level, but also the pharmacy is also communicating with other stakeholders as well. The provider, maybe the field reimbursement manager at a pharma company, or even sometimes the payer. All right. Here I have a pharmacy can submit the PA on behalf of the provider's office, and that's usually with specialty pharmacies if they contract with a clinic or with an office. Some of the roles involved here at the pharmacy level in this prior auth process at this stage, of course, are our pharmacists, our pharmacy technicians, but some other roles we see involved are managed care professionals, so managed care pharmacists, patient care coordinators, or medication access coordinators as well. Alrighty, so we've gone through 3 players in our game board, leaving one more. Some may say is the most important, some may say is the most annoying. Right? This is our payer organization. And by payer, this is really a collective term, right, describing insurance companies or PBMs. And ultimately, the payer's role in this process is to make that final decision. Once they've gotten all of the documentation that was sent in from the provider's office, they then have to make that final decision, whether they're requesting for more information, but those final decisions are either an approval or, of course, a denial. Right. How do payers decide what is covered? What is going to be improved on their prior authorization? Right. They are comparing the clinical documentation that was sent in from the provider in the provider's office, and they are comparing that against their own pre-built formulary. Okay. What I have here on the screen is pretty important. This is a really hot topic right now in the case of Humira biosimilars. If you're not aware, Humira, the brand Humira, this particular biologic has been the #1 selling drug globally for over a decade, right? Humira's patent expired at the start of this year. So when that patent expired, we got an influx of biosimilars or copies of Humira itself, right? This is great. We have, as of now, 9 Humira biosimilars available. This is great for innovation. This is great for competition among pharma companies. This is also great for patients, right? There's more alternatives. There's lower cost alternatives to Humira that are available for a treatment plan. But where this comes into play here for our payer organizations is that a health plan is not going to include Humira as well as all 9 biosimilars onto their formulary. And so the question comes in of how do payers actually decide which to include on their formulary? We're really just waiting to see which biosimilars are going to be included on specific plans versus others. And this is important for physicians to be aware which biosimilars are available for the rheumatoid arthritis patients, right? All right, so the payer's role in the prior auth process, like we mentioned, their main role is to review and evaluate the documentation or those clinical justifications that were submitted from the provider's office, right? They're assessing the documentation that was sent in against the coverage criteria that they've already set. And based on that comparison, they're going to make their final decision, whether that's an approval or denial. The payer player, they also play a major role in communication. They are key in communicating their final decision to the provider, to the pharmacy, so that we can resubmit, and also to the to the patient. So some of the roles that are involved at the payer side, right? We have coordinators, prior auth coordinators, we have those reviewers, we have medical directors. But the issue here on this side of the roles that are involved is that oftentimes at the front line, those who see the clinical documentation first, what I hear is that they don't have clinical knowledge or clinical background, at least not extensive clinical knowledge. And that becomes an issue when, let's say, for example, the formulary or what they're reading says this particular drug is for hypertension, okay? What comes in that was submitted by the provider's office from that medical assistant It says this drug is used for, we're submitting for high blood pressure. If that person at that front line who was comparing those two at first, they're reading these and comparing the coverage criteria against that clinical documentation, they're going to deny it, right? And we see why that's a problem, right? They're denying a medication now that is vital for a patient because they haven't recognized that hypertension and high blood pressure are used synonymously. Alrighty, so we've gone through all of our players. We've gone over all of our game board, all of these arrows, and we followed along the journey of each. We've seen the perspective and the issues that arise at each stage. Now, why is this an issue? All right, so we've gone over that prior authorizations, they restrict and they delay care for patients. They become an administrative burden to physicians, right? They're taking time away from direct patient care and using those 14 hours each week, right, to submit paperwork, to submit the clinical justification. It's also an issue among physicians because we hear that they feel as if prior authorizations undermine their expertise, right? From the physician's perspective, they have built a treatment plan for this patient based on their clinical judgment, right? They are specialists within this particular therapeutic area or this disease state, right? They have built this treatment plan based on clinical guidelines that are out, clinical practice guidelines. And now you're telling me I have to justify and explain why I've made this decision because of an insurance issue, right? So a lot of physicians feel as if this undermines their expertise. So how can we make prior authorizations more efficient? Prior authorizations, they aren't going anywhere anytime soon. So how can we improve this process? Right, removing a few of those barriers that we've talked about, we can advance technology, right? Technology, including AI. AI itself is being introduced into healthcare like nobody's business. On the payer side, they are now introducing AI to be that front line to try and make the process or the decision-making process even faster by comparing what was submitted by the physician to that criteria for coverage immediately. Right. The ACMA, we have also introduced an AI tool specifically for field reimbursement teams or market access teams within pharma, so they can have that insight at the drop of a dime, right? We can also improve training, right? Improve training of all of those roles, all of those titles at each stage in the process through certification. And that's where the PACS program comes in. Right. The Prior Authorization Certified Specialist Program is an accredited certification that is recognized industry-wide among hospitals and clinics, among pharmacies. You can find PACS credentials in pharma, right? Those field reimbursement managers and market access teams as well. So at the ACMA, we have introduced the PACS program, the AI tool, as a strive to increase and set standards of excellence within the life sciences industry. Right. The PACS program itself was built and developed and designed to enhance teams so they become best in class when it comes to submitting not only just prior authorizations, but successful prior authorizations. Right. Through these efforts, we want to transform patient access and advocacy. All right, so let's dive into the PACS program. What's included into the Prior Authorization Certified Specialist Program? I mentioned that it's accredited, but what's different about PACS is that it's completely online. So with all of our content being online, a learner can completely go through the program at their own pace. There are no lectures you have to attend. You just, whenever you're ready to go, the content is ready for you as well. You see a phone here on the screen? That's because our content is also available via desktop, tablet or iPad, as well as on your mobile phone as well. When we're taking a look at our target audience here for the program, those who enroll into the PACS program, they fall into one of those key players that we talked about earlier. Right, so those at clinics and hospitals, our healthcare providers, specialty pharmacies specifically, those among the market and patient access teams, as well as payers and PBMs. We go over the prior authorization process, the healthcare and insurance landscape within 12 modules, again, all online. A learner, when they enroll into the PACS program, they then also gain access to case studies. What we found with prior authorizations is not enough for us just to throw content at you where we're going over the insurance plans, we're going over the steps to take. We really want you to dive into real life examples. And that's what these case studies provide, to where you can apply the content to a real example. We also include in the PACS program downloadable resources. These are available throughout the modules, as well as a toolkit at the very end. What we found beneficial for those completing the PACS program is in that toolkit, there are templates that you can use. Templates that you can tweak whenever you're communicating with the payer organization, whether they're forms or emails, right? We provide those templates for you. We also have at the end, a final assessment, and that's how you become certified as a PACS credential. So what does the PACS program even talk about? When we're looking at the curriculum overview of the PACS program, I want to address the content by taking a look at each player that we went over before, right? We really want to enhance the perspective of each player within the process in one place, within this one PACS program. So from the patient's perspective, we go over the patient education, how to speak to patients and explaining prior authorizations. Right. We go over what services and patient-assisted programs are available for patients to move them along that prior auth process. From the provider's perspective, of course, we go over the prior auth process and those workflows, but we also give those best practice recommendations from the very start on how to better your entire staff when approaching prior authorizations. Right. We know that clinical documentation is step number one. We go over that more in depth. You see here service line and medication requests, right? The PACS program, we don't only cover medications when it comes to prior authorizations. We also go in depth for prior authorization requests that address services such as procedures or those diagnostic tests as well who require prior authorizations. From the pharmacy's perspective, we go over prescription requirements. We go over the anatomy of a prescription. We go over the coverage determination types, the medication tiering, specialty medications. You also see Cover My Meds here, right? Cover My Meds is possibly the #1 portal for submitting prior authorizations. We go over that in depth. We go over the troubleshooting that is required for prior authorizations as well. And then finally, from the payer's perspective, of course, we're going to go over insurance policies, Medicare plans. I mentioned the insurance medication tiering. Right, and also their formularies and how they're built. So I mentioned that the PACS program is accredited. This is an accredited certification. And so at the result of the program and the successful passing of the final assessment at the end, those who go through the PACS program now have a credentialed lettering that they can add after your last name, the PACS letters. From a professional development standpoint, this is important because you can add it to your resume. Right, your CV, your business cards, your email signature, right? So from the outside looking in, outsiders now know that you're an expert in reimbursement. You're an expert when it comes to prior authorizations. Okay. Again, proper education and training is key, and that's where the PACS program came in. All right, this is the first step in enhancing and streamlining patient access to medications. And by becoming an expert, we see either on the individual level or on the team level, we see an increase in effectiveness among the team. By becoming an expert, you also enhance your confidence, right, in your process of streamlining patient access to those vital medications, to those vital services. Alrighty, so we've gone over the different players, the game board of the prior authorization process. We've gone over the PACS program. Now, if you have any questions, you want a more in-depth review on either the PACS program or our AI tool that we provide, the Field Reimbursement AI, we do have a booth in our exhibit hall, right? We are at booth 204. Right, you can find my colleagues here, Allison and Annie, and they can give you more information. You can email me here. Here's my email. I'm always available. I think we have a few more minutes. I think about 10 or 15 more minutes. So if you have any questions, we can go ahead and address those here in person as well. Thank you.
If there are any questions, I will be coming around with a mic, so just flag me down.
Thanks for the presentation. Are there any systems that alert the physician that a prior authorization is required so that they address that in the workflow and it doesn't go all the way to the pharmacy and follow the
Yes.
roadmap you identified?
Yes, there are. So they have CDS systems. So these are clinical decision support services where they are actually tied into your EMR. They'll have to be able to talk to each other. A lot of EMRs, they have those support systems already built into the EMR, and we're seeing these more on the rise and being used so they can alert. Based on an insurance plan, they'll let you know what's the first line. I don't want to use first line because that's what we use in clinical practice guidelines, but they'll alert you if that's first on the tier or medication tiering for a particular patient in their health plan.
That system will have access to the medical policies of the insurance.
Yes, but it's tricky because, right, the formulary, they change sometimes at the drop of a dime or the introduction of a new medication. So trusting your EMR, trusting your CDS, that's the first step. Great question. Thank you.
I'm just curious about how many credential PAGs there are and what are most of the population? Do you see most doctors? Do you see clinicians? Do you see nurses?
It's a great question. So currently in PACS, we have over 3,000 PACS credentialed. Where we find them the most, again, are usually in the direct patient care level. So in the pharmacies and clinics and hospitals. As of late, we're seeing more field reimbursement, so those who work in pharma, so that they can better communicate with their stakeholders, which are clinics and hospitals, which are specialty pharmacies.
Thanks for the presentation. I do have my PACS certification, and I would be really interested in knowing if ACMA has any other additional certifications for instance, I'm a field reimbursement specialist, if there's anything else planned in regards to certification.
So as of now, within this realm of patient access, this is our only certification. Now, with your team, I don't know, did you certify as an individual or with your entire team?
I'm certified as an individual, but then since then, our team through Syneos Health has certified as a team.
Yes, I'm very familiar with Syneos. So with Syneos and others, we also have the possibility of custom training. This is something that we're looking to build now. Over the next, I'll say, year or so, we're looking to expand out to specialize, so therapeutic area specific content. And so with that, we're going to do a field reimbursement training, like copay maximizers and accumulators, what those mean, and how you can handle patient education materials. So possibly within the next year. I'm sure Syneos will tell you. Syneos and ACMA, we're like this. I would say it's more so with cost. All right. If on the individual, you're paying yourself. You could get it reimbursed with your employer, but speaking to your decision maker, your medical director, if you have one, so that they can certify the entire team, then they'll pick up the cost for you. They'll have a account manager who can make sure that everyone goes through the program at an easy pace. We'll give you those best practice recommendations there.
I actually have a question. So I work a lot with like the specialty medications, and we see a lot of buy and bill, right? I noticed on the presentation, it had a lot more to do with the pharmacy side. And I know buy and bill's kind of been around for a long time. Do you guys plan on like adapting more like the medical benefit side to your, probably the PACs specifically?
Yes, that's definitely in talks as well. So we update our content quarterly. Buy and bill is something that we're looking to introduce at the start of 2024. Like you mentioned, buy and bill more addresses the medical side, where we go over in PACs, procedures and services such as those. We go over J-codes, right? J-code medications, but buy and bill in depth is very specific, usually for either the agent or the therapeutic area. And so that's where, again, that custom training for therapeutic area specific content is coming in.
Awesome. Perfect.
Great question.
This seems to address a lot of the entry level and standardizing through making the entry level qualifications and knowledge standardized. As far as continuation, do you see any need or do you see any benefit from continued education, kind of like when someone maintains a certification for oncology specialties and things like that?
Yep. So PACS, similar to other credentials such as those, we do have a continuing education requirement. PACS is renewed every 3 years. And we provide those CE credits or that content for you to maintain your license with PACS. And so we do that through those continuing education efforts as well.
One more from me, and that is what is the difference that you see in staff where PACS is maybe implemented after the fact? Do we have case studies that show evidence of how much this is quantified as benefit-wise?
I'm glad that question came up.
And in which of those categories do you see the most? The patient, the provider, the payer?
So we are actually undergoing some studies right now. We are calling the PACS Impact Study, PACS Impact Research Study, where we are assessing the prior auth process when it comes to time and when it comes to money for a particular team when it comes to prior authorization. We assess it before you see any content within PACS. Then the team themselves will go through the PACS program and learn more with those case studies. And after a few months, we'll do a follow-up and assess again time and money so that we can put our testimonials that we have to numbers. So right now, the level of the data that we're getting, they're at the provider level. So they're clinics and hospitals. No date on when we'll be releasing those either, by the way. We're just kind of collecting currently. Good question. All right, I don't think there's any questions. Again, I attended HAS last year. I learned a lot. You'll probably hear prior authorizations a lot throughout your sessions. Throughout this week, I really suggest that you take your time with the sessions, visit all the exhibitor booths to learn more. Stop by my booth, our booth at 204, talk to me a little bit more. I'm pretty nice. But yeah, just take advantage of HAS. You really learn a lot here. Thank you.
Awesome.